Everyone, and welcome to the American Psychiatric Association headquarters in Washington, D.C. So good to see you all here in the room, as well as welcoming those who are with us virtually. This is the APA More Equity in Mental Health Roundtable discussion on building support for young women's mental well-being. My name is Dr. Regina James, and I serve as one of the Deputy Medical Directors here at APA, as well as the Chief for the Division of Diversity and Health Equity, and I'll serve as your host and your moderator. Just to give you a little bit of background about the More Equity in Mental Health initiatives. They're held each year here at the APA in the month of July. Why July? Because July is officially B.B. Moore Campbell Minority Mental Health Awareness Month. And this roundtable discussion today is the official kickoff of our slew of More Equity initiatives. So we have two goals with our More Equity initiatives here at APA. One is to recognize the hard work of the advocacy of Ms. B.B. Moore Campbell, who was a very staunch mental health advocate for communities of color. But secondly, it's an opportunity to connect our APA members with various communities so that we can raise awareness about the importance of mental health. So through activities like this one, a roundtable discussion, as well as others, we have a health fair, we have a 5K event, we have a youth mental health summit. And so all of these events are really to bring more awareness and education about mental health and mental wellness. Now this afternoon, as I stated earlier, we're kicking off More Equity in Mental Health with this roundtable discussion, building support for young women's mental health. So when we talk about women this afternoon, I want to make sure we're all on the same table, that we're going to be able to address the intersectionality of being a woman. Being a woman and being Black, Latina, Asian, or Indigenous. Being a woman and living in a rural or urban community. Being a woman and experiencing different social factors. Why is this conversation important? I think the data from the Center for Disease Control and Prevention will help underscore and bring light to why this conversation is so critical and timely. So in 2023, the CDC released findings from a national survey, and the survey revealed that there was a significant rise in mental health challenges for our young adolescent girls. So about 57% of school-age high school girls were experiencing persistent feelings of sadness and hopelessness in high school, right? And compared to the young men at the same age, they were nearly twice as likely to experience this. In addition, about 30% of girls said they had seriously considered suicide, 30%, and 13% actually had attempted suicide at least once. So this roundtable discussion will help us explore unique mental health challenges experienced by young women across populations. We will examine contributing factors to these mental health challenges and discuss actionable strategies so that we can, 1, support early intervention, and 2, find ways to strengthen referral pathways and connect young women to appropriate mental health services. So now, as you can see, we have a very, very esteemed panel of leaders in psychiatry. They will help us better understand how to promote and build support for young women's mental health and well-being. So I will introduce each of them, starting at my far right. We have Dr. Teresa Miskimen Rivera. And Dr. Miskimen Rivera is the President of the American Psychiatric Association. We have Dr. Marquita Wills. Dr. Marquita Wills is the CEO and Medical Director for the American Psychiatric Association. We have Dr. Narpinder Malhi. Dr. Narpinder Malhi is the immediate past chair for for the Assembly MUR Committee and serves as the Director of Child and Adolescent Psychiatry Clinic and Multidisciplinary Autism Program. And last but certainly not least, we have Adriana Minigotes de Julio, who is the Chair-elect Assembly MUR Committee and also Medical Director at Aurora Mental Health and Recovery. So again, we have a very esteemed panel here of psychiatrists, and I hope that our discussion will be fruitful. I know that we will all learn a lot, and I'm so looking forward to starting our conversation. Okay, so let's start off with, and I also wanted to mention that I do have questions here, but we strongly encourage questions from the audience here at APA headquarters, as well as those from the virtual community. So I'm sure one of our staff will let me know when we have a question, and I can just interject within the ones that I have, just to make sure that we all get our questions answered. Okay, so I'll start with this statistic. Approximately 70% of rural United States counties lack a child psychiatrist, with many communities facing limited mental health services and long travel distances. So, panel, how can community-based approaches be leveraged to improve access to mental health care for young women in rural areas? And I'll start with you, Dr. Miskimen Rivera.
Thank you so much. And first of all, thank you for the panelists and also for Dr. James to inviting me for this particular panel. Why is it important to me as a Latina and as a Latina psychiatrist is that I see some of this intersectionality based on my clinical experience, and this is what we do every day for our most vulnerable populations. So thank you for that. And to respond to your question, I think that specifically in rural communities and for Latina patients, there definitely has to be that community-based approach, because we know that for the Latina population, the adolescents, we have a higher risk of suicide in our midst. And that has been growing, especially after the pandemic. And we know by research that some of the most influential interventions that we can have are community-based. There's a specific connection that the Latina population has with the community, and I'm looking at school-based, faith-based, and having that directly in the community becomes critical, especially as we move for prevention of suicide specifically.
Thank you. Would anyone else like to comment?
So as Dr. Miskimen was saying, the need for rural community is very demanding at this point. We have lack of child psychiatrists. As per American Association Academy of Child and Adolescent Psychiatry, the projection is right now we have 9 to 10 child psychiatrists per 100,000. What we need is 42 child psychiatrists per 100,000. So there is a significant gap in providing the care to our young growing population, and specifically we know that women are at a higher risk anyways, so adolescent girls are at higher risk. And some of the community approaches that we have introduced within our community, we do serve, like I come from Delaware, and we have a lot of regions of South Delaware where there is a lack of specialized services, especially mental health services. There's, for our Sussex County and the Kent County, there's only 1 or 2 child psychiatrists for the whole 2 counties. So utilizing telepsychiatry has been our one of our main strength, and acknowledging the need and collaboration through community health workers have been very, very successful. These are they bridge the care between the psychiatrist and mental health professionals and going out to the communities to do that outreach so they can bring those services to them. That has been very, very successful. So there are evidence-based approaches that we can utilize to address the deficits in the care.
I think speaking to your thoughts there, the collaborative care model in Colorado has become absolutely vital. That means psychiatrists in urban areas like Denver and Colorado Springs can be reaching out to almost 85% of Colorado's rural reaching out to primary care offices, smaller clinics that are social worker run or psychology run, and giving advice, curbside advice, or actually really consulting with those clinics, primary clinics in rural communities. I think having that touchstone, though, in the community, as a community center, is vital. Even if a clinician, maybe a psychiatrist, isn't there specifically, they know that they can go there, see a nurse or a social worker, and that via telehealth, a clinician that's a prescriber, be that nurse practitioner or psychiatrist, will be there to take care of some of those needs. And I think it's going to be more important over the next few years as we see community health just struggle with some financial things.
Okay, thank you. Now I'm going to switch my question to focus more on social factors. And so, Dr. Wills, if you could maybe address this question. Among 18 to 24-year-olds globally, lack of in-person socializing is 2 to 4 times more predictive of mental distress, after sleep actually, than financial hardship. To what extent do you think neighborhood and social factors like lack of social connection and unsafe environments increase mental health risks for young women?
Well, first of all, thank you for pulling together this panel. I'm very honored to be on the panel with these esteemed panelists and glad to be here. And thank you, Dr. James, for your leadership. Social factors. Social factors in women's mental health are incredibly important and an important determinant of mental well-being. And not just any social factors, it's got to be positive social connections. You don't want social connections that are deleterious to one's mental health, but ones that are supportive and uplifting. And so it's important for everyone to invest in positive relationships. Loneliness, as we know, is certainly a risk factor for mental health conditions. And so being plugged in, whether that be organically and naturally through hobbies or faith communities or shared interests, through sports, through other ways of being connected to groups of people with shared like interests, is a protective factor for mental health conditions. And it's particularly important in young women, as that's an age where online and in-person bullying can impact a young person's mental well-being. And so having nurturing relationships is critically important and should be sought out by the families of young women to ensure that they are meeting their developmental milestones and progressing along that way. So I would assert that social factors are critically important in a foundational well-being. It's also one of the 6 pillars of lifestyle medicine and lifestyle psychiatry is having those positive social connections. And so making sure that one is deliberate and intentional about that is important.
Thank you, Dr. Wills. Any other comments?
We did see the decline in mental health in COVID, and that is evidence for us that lack of that social connection and heavy reliance on social media presence can be so much detrimental to mental health. So we do have like significant evidence after the pandemic, the importance of social factors.
You know, and it's interesting that we have more in common than not. And this is something that it doesn't matter which race, ethnicity, where you come from, it does affect generally. And making sure that we are reaching out, especially to our young women in our communities, becomes critically important because as they have this increased risk inherently because of their gender, the loss of, if they're depressed or if they die by suicide, the loss to the community, to their families, also has to be accounted for.
Exactly. Thank you. Okay, so Dr. Malhi, inadequate access to qualified professionals limits about 46% of rural schools from offering mental health services. So we had an earlier question about rural health, but this is going to be around programs and identifying early signs of mental health challenges. So whether it's the role of the school or youth programs or faith-based institutions, how do you see those entities playing a role in early identifications of signs of mental illness?
Yeah, that's a very good question. I think that should be the approach that we should be looking forward in future. How do we connect to these youth where they are rather than having them come to us? So one of the programs is like that we have implemented is school-based psychiatry, where we have therapists in the schools doing the mental health screening for these children and educating the other school professionals, including support staff or teachers, to look for the signs for decline in mental health in our youth, including in elementary schools, middle schools, and high schools as well. So I think that is the critical portion, that how do we come to the preventative strategy? How do we catch these mental health risk factors at an early age to implement how we can prevent them from getting worse in the future? And another thing that we have collaborated with is community health centers like YMCA or other centers where we can see our youth who are unable to come to us, but we get to do the outreach to get to them. So those are like faith-based communities, community health centers, school-based. These are going to be the future for us to do these interventions in the near future.
And I think speaking directly to what interventions, we do a similar program at our Community Behavioral Health Center, CBHC. We have we call them embedded teams in schools across Denver, Arapahoe, Douglas County, some are more rural counties. And we use two specific tools, the CAM model, collaborative assessment model, to look for risk. And then we use SAFE-T, which is another model that came out of the clinical side, the psychologist side, but we've now trained all of our clinicians. We've trained teachers, we've trained principals, and the safety resource person, which is kind of like a school security guard, on these two models, which have proved to be pretty successful, and that's nationwide. These two programs, CAM and Safety, have been utilized, and I think are very successful in schools, at least. Mm-hmm. I can't speak to, outside of that, but yeah.
In New Jersey, we also have been using a lot of that school-based community outreach. And where I work, they also pair it with our crisis intervention team. Mm-hmm. And it's an immediate way for the teachers who already have been educated on how to pick up on these particular flags that you were talking about. And if there is immediate need, we will be able to have a crisis team go directly to the school, which really is an incredible tool. It's right there, it's happening immediately, timely, and we've had really good results with that. And I got to put a push and a shout out to the American Psychiatric Association. Has the program through the foundation of Notice, Talk, and Act. And that is, it's a great resource to have. Those of you that are listening today, if you're interested, it is a program that they train your school staff members, and they will be able to then provide some of the immediate instruments to be able to identify and then what to do with that information, and then connect, which is the most important thing. You finally then connect them to the resources in the community, because it is tailor-made for your community. It's a plug, but I wanted to put it in there.
I'm glad you did. It's an important plug. Notice, Talk, Act. Another one is mental health first aid, but having folks in the communities that are in the front line, so teachers, clergy, deaconesses and deaconesses, coaches, et cetera, making sure that everyone in the community approaches mental health, workforce, work environments, approaches mental health from a public health standpoint, from a standpoint of we've got to, as a community, take care of those who are living with mental illness and substance use disorder. So I'm really glad you brought up No Just Talk Act.
So one of the things, another thing I like to add there is the intervention part. Like what we have implemented is with our therapist integrated in the schools is the universal suicide screening. Like whenever they have a visit, even if there are not as many obvious risk factors, we want to make sure that we do not miss our young people who do not have obvious risk factors. There is a recent study that got published in this June American Psychiatric Association journal that the risk for not so much, the risk for people who don't have that obvious risk factors is also getting higher, the risk of suicide for those kids. So we don't just have to look at people who are at high risk. We can't ignore for the young population that may appear like that there are not many obvious risk factors, but they're still, those are the ones that get missed and end up having a real suicide attempt at later date. So really having those resources embedded and having some interventions that how can we intervene at early stages is very helpful.
Right. I know that the American Academy of Pediatrics actually recommends
universal screening, yes.
How common do you think that actually is?
So within our field, within mental health professionals, we are very comfortable with doing those screenings and appropriately allocating resources to this patient population. But we have to acknowledge that our peers in other disciplines like pediatrics, their training is not as robust in mental health care as what we will do. So we are trying to implement in the emergency rooms, in all the primary care offices, any touch point where you come across any health professional, so that we do not miss the opportunity to help. But we have a long way to go, to answer your question. It is not as prevalent as you would imagine, considering the recommendations from national societies.
And isn't the barrier is that a pediatrician sitting in their office and she or he or them are looking at a child and they're thinking, if I do screen, then what am I going to do if it is a positive screen? Mm-hmm. And then if we haven't, as psychiatrists and as organizations around mental health, already reached out to primary to give them our crisis response team, because we have a few of those, or our contact for Ascend if we have a young person experiencing psychotic episodes for the first time and a clinician sitting in their office, they're very wary of doing that. Often what happens is it's just 911 is called. And maybe that's actually re-traumatizing and traumatizing for the young person rather than another stepwise path that could have been taken. But we're beholden to give that pediatrician that opportunity or internist that opportunity to have somebody else to call besides 911 or 988.
And this is where education, as psychiatrists, what we can do is that we can really push for that education. Mm-hmm. So there are many programs in my neck of the woods in New Jersey. We have this specific collaborative. So it's psychiatrists and pediatricians, and the psychiatrist would be able to do a consultation in real time with a pediatrician, state funded. So we have it across all 21 counties. And that really pushes the education for pediatricians. They can just call up that number and ask about, I have this case here. What do you think I should do about it? Does the patient need to go maybe to an individual therapist? Are we looking at emergency room? It's that push for education. So as you are moving through your lives, again, it's very important for us as psychiatrists to really advocate to increase the education throughout the community. So we're looking at school-based, as we said, the faith-based, of course, our peers in the House of Medicine. But it's an education push that I think psychiatrists really can help a lot at this point.
Great, great.
Agree.
Thank you.
Good point.
So, Dr. Minnick goes to Julio. Young women ages 18 to 24 living below the poverty line are more than twice as likely to report frequent mental distress compared to those above the poverty threshold. So talk to me and talk to all of us about how does income inequality and poverty contribute to mental health challenges among young women? And then second, what interventions you think are most effective in mitigating these risks?
Yeah, I was one of those young people living below the poverty line all of my childhood, and I grew up in a very rural area on the Navajo reservation with not a lot of resources, and the rates of addiction, suicide, domestic violence were astronomically high, and still are on indigenous native lands, and even indigenous people living in urban places, young people experience higher levels of suicide and addiction, even if they're not living on reservations and they're in the urban area. Poverty is a difficult place to be in. Looking for clean water, meals, clothes, knowing your family can't provide, knowing your family may have addiction, knowing your sisters are incarcerated, that was like my story, and kind of having to struggle through that is just an everyday part of what becomes your identity. And I think a lot of young women, a lot of young men, when they're in poverty, feel as if that is their identity. They're a poor person. They're not a person. They're not themselves. Even if they have something, a wonderful gift. I find schools were my way of getting out of that cycle, academics and sports. My local church had programs, and I was also, taken care of a little bit by the healthcare system, but I think that trying to break that we're not just poor people when you're poor, and form different connections with the community, but that requires outreach into those poorer communities. And for me, language-based, so speaking my language, I spoke Navajo and Spanish. That was really important to me. But it could be speaking New York or Detroit or whatever your neighborhood is. Somebody who could speak that to me and who cared about me and said in my native tongue, you're a beautiful person, walk in beauty. You're not just a poor person. That's where poverty gets really, really into the trauma part. So knowing about trauma-informed and historical trauma is really important as clinicians. Why are we poor? I wasn't born poor. I was born on this beautiful land, but I'm poor now because of colonization or because other people may have a different story. Somebody who can speak that trauma-informed, culturally aware language to me, to break that is very important for what we're going to be looking to help young people break out of the cycle of poverty and addiction. Is that an
Yes,
answer?
and you actually touched on a number of areas: cultural sensitivity of the healthcare provider, just connectedness, community engagement. All of those things can help mitigate some of the issues.
Yeah, it was a long time before I met a doctor who was indigenous in my lifetime. Growing up, I had Caucasian providers mostly who worked for Indian Health, and it was a long way into my journey. And when I met some of those people, it really changed me. But there were people who were allies who could speak my language still, and I think one of my goals is to teach my clinicians how to speak that language to poorer people. In Denver, where I work, we have a huge Burmese immigrant population. You may have seen this and we have a huge Venezuelan population. You may have seen that on the news in Aurora, Colorado. And teaching my clinicians to understand why these people are fleeing Burma and Venezuela as refugees was really important. So we did a huge trauma-informed care, but also utilized translators who could really get into the community to understand. And so, like I said, language is important. And then younger mentorship is really important too in poor communities. So you have someone to look up to that has gotten out of that cycle.
I'll just add one more thing. While Dr. Manigault was talking, I was also thinking for young women, I think for women, we've been at somehow not as much privilege compared to our male peers. So pay parity is so important, to address this poverty, even when we are as a women physicians, we undergo that barrier ourselves. People who are below poverty, I can't even imagine that it doesn't exist there. So having advocacy, being involved in advocacy or policy level interventions, if you have an opportunity, I think that's what all we can do together as a collective to build that path for our young women or rising women.
And you gave just a simple example before we started this. We were talking, and she said it's minimum wage. If you have the opportunity in your community, the persons it's going to affect are women because we're underpaid and poor people. So vote for higher minimum wages, advocate that, use your voice to do that. Not just as such a simple thing that you mentioned, and I wanted to bring up because I thought, wow, yeah.
Okay, so back to you, Dr. Miskimen Rivera. Among Black and Latina adolescents, exposure to discrimination is linked to a 2.5-fold increase in depressive symptoms and suicidal ideation. Can you talk about how lack of cultural belonging affects the mental well-being of young women of color in general? Let's start there.
So actually, I wanted to jump also on, first of all, thanks for sharing. Yes. But in terms of that connectedness and where is it that we as psychiatrists can really help out is to really understand the cultural background of our patients. What came to mind as you were talking to me is that there were times in which I speak Spanish, I'm from Puerto Rico, so somebody that was from another Caribbean island came to my clinic, and the circumstances of why they were here in the United States were so different. That even though we're from the Caribbean, it's an island, right? So it's like, what's the difference? It's the Caribbean. Very, very distinct ways in which, why is it that people came into USA, what the cultural background is, even the language and the baggage, both positive and negative, that people bring into that particular experience. So to your question, I think that what I have really focused in, especially when treating women in my practice, is to first of all understand where they're coming from. What is it exactly that they want? What is the goal of them coming to see a psychiatrist specifically? Because the goals are different. And I think that that's the first step. Goals could be different, and the socio-demographic aspects of it really have to be brought in. And I know that a lot of psychiatrists were doing a lot of pharmacotherapy, and I really push residents that I train over the years. You need to get to the core. What is important to that person? What are the social determinants of health that have brought that person in, so that you can then incorporate? Because the way that people come to you and what is it that they want really should inform what it is that you're doing for that patient. So I hope that answers that question.
Absolutely, absolutely. Does anyone want to?
I'd also love to jump in there. Great answer, Dr. Miskimen Rivera. Building on that, I think that discrimination, being discriminated against is taxing. It's mentally and emotionally exhausting and taxing. And many times it happens, and the person who's perpetrating the aggression may or may not be even aware of the fact that what they've done. So then there's piece of like almost denial or gaslighting that happens, where people aren't even, their feelings around being discriminated against or being talked down to are minimized and erased almost. And so that can be very, very taxing. And just one way that I found in working with patients who are oftentimes feeling beat down by being discriminated against and living in ways that feel oppressive and that are oppressive, is also trying to turn that around on its head and upside down, and finding sources of strength and resilience. And I know many times people are sick of being resilient. It's like, I've gotten knocked down so much, it's hard for me to want to get back up. But building in that capacity to deal with the insults, the assaults, the things that may happen, and those things absolutely do pile up and impact one's mental health. But finding ways to find strength and inspiration in one's own personal story or journey, and one's own cultural story and journey, and holding on to those as a source of hope for those that follow in one's footsteps, I think, are ways to combat some of that discouragement that can happen.
It's the rewriting of your narrative, right? Cornel West said something the other day. He said, research your history, know your history, and tell everybody your history. And he was doing this on a Juneteenth discussion. It really resonated. Write your know where you come from. Write your narrative. Tell your narrative. Say it with pride. Say it in beauty.
Yes.
That is a good lesson to give to every person and every patient, and young women especially. And just to highlight, young women are so prone to sexual assaults on social media, sexual violence, eating disorder violence, all sorts of things that other young people, especially young men, and transgendered persons of youth are very susceptible to these things. So telling them about knowing their history, knowing their narrative, write their narrative, be proud of it, is something we really have to start encouraging.
Storytelling is something that, and it's not only a Latino thing, I know that. All of us here in this particular panel, it really is part of our culture. And to know what it is that your patient brings in, that story is so critical. I think that the most connection I've ever had with patients, it's when I have taken the time and made an effort to not only hear it, but understand it. So I cannot agree with you more.
How can we push that more? The message of taking the time, because people feel like they don't have much time. How do you balance that?
Personally, one of the things that, as an administrator, one of the things that I really took care about was managing the time that the clinicians that I work with had. So I know that there's a big push to see, 5 patients per hour, but that is something that as a psychiatric administrator, I was able to always take back to the CFO and say, it might be an immediate gain for you to do that, but I can tell you that in the end, we're going to lose patients because in 10 minutes, it's difficult to engage, especially in psychiatry. Now, I think that for psychiatry versus like primary care physicians, it's a different focus of attention. And because we do work with the biopsychosocial model, that does require extra time. And this is something that, again, as a psychiatrist, and if you're a psychiatrist administrator, to advocate and know the economics of why is it so important to take the time to do a thorough evaluation, not only for diagnosis and what is it that you're going to be putting it as a treatment plan with the help of your patient, but at the end of the day is about providing the time to engage. So that's what I've done in my neck of the woods.
I think one thing I can add to that is that when we look at our reimbursement rates, we need the leadership, to keep advocating, the leaders that can go on the front and work for those clinicians so we can get the value of the time, the care that we are providing. So that can become then negotiating factors with the organizations. How do you balance the business versus the patient-focused or patient-focused, narrative-based care that we want to provide. So we all can strive for that goal, but especially the one who are in leadership role can certainly aim for those goals.
Yes.
I'm kind of thinking about young women. It's important to hear their story because I think they're so often not validated in society. They're just sex objects. They're just beauty or not beauty. They're not really looked at as
intersectional.
intersectional. And so when they tell the story, actually lean in and give them the time, and then actually try to listen and follow up and repeat back, get clarification, and then know they're not alone. I mean, I don't suggest clinicians share their whole life story, but I will often share that I have had my own struggles, that I have a person too, and then bring in who's their support. That may be their best friend who's also 16. Okay, bring him on in. Mom, a dad, an adoptive parent, a foster parent, because then the story becomes our story, and they're really not alone anymore. And oftentimes I think clinicians just don't ask, like, anyone, you want to bring your best friend here next time? They're like, oh, yeah, that sounds fun. And then you learn about the community, and they feel so much more validated by that. But that does take time.
I agree with your human connection.
Yeah. So, Dr. Wills, you had mentioned in your earlier comments, I'm tired of being resilient. People are just tired of being resilient. There's this thing called the superwoman schema, right? The superwoman schema is like this cultural expectation that you appear to be strong and resilient and suppress your emotions, which is, of course, more common in women, superwoman schema. You mentioned some ways that we can begin to address that. Can you talk a little bit about some of the things that you do? And in particular, I know that you are a yoga teacher, and just some of the ways that people could, pearls that they could take back with them today about how do I deal with this? Yes.
Woman expectation. And I think many of us fall victim to that, we have to be twice as good to get half as far. There's that sort of mentality, and perfection is the necessity. And I try to combat that with really authenticity and vulnerability about parts of the journey that are challenging, that are tiring, that feel like I need a load, that I have a load and need help. Mm-hmm. And so I try to be transparent and authentic about, in fact, not being a superwoman, about having had many, many, many failures. As many times as I've failed, I've gotten back up every time, plus one, right? And trying to share that so that other women with whom I come in contact can feel more empowered to be their full selves, and not just this exterior where, you're trying to exude this, hyper confidence almost. And I think it's the humanity that makes us really real. So trying to have those authentic connections, being vulnerable and sharing, telling about challenges, and always giving room for being human. I think that's something that's just really important is, we're not machines. We do mess up every day. We do have setbacks. And then also recognizing that those setbacks aren't the end of the world either. Oftentimes they're the best fuel for learning, for growth, if one approaches them with that growth mindset. So I do my best to try to shatter that superwoman schema, because I don't think that it serves me personally well or any of my other female colleagues.
Any other comments?
Love to hear what others have to
Because
say.
we have all these leaders here, and I'm sure you're all looked at as super women leaders.
So I have to jump in because it resonated with me. So when I was younger, I was so into the superwoman, and it took one of my mentors, a woman mentor, to tell me, you gotta slow down. What are you doing? And I think that had this particular person not sat me down and said, you got to stop at a crucial time in my career. And this was at a time when I was trying to climb the academic ladder. So there was a lot of research, papers, all the things. I had kids. And it was overwhelming, for sure. And I think that there are two things that helped me. Getting a good mentor. She was awesome. I still have her on my Rolodex of mentor. And this is how old I am. I have a Rolodex. But in any case, the other thing that I came out of this is that you really need to rely on others and to be vulnerable and say, I need help. And I think that especially for women, and I know that adolescents, we're trying to focus on adolescents, but mid-career women, I think that have it really hard because it's a time when you're trying to succeed in your career. And you also, if you decide to have kids, that would be the time in which you still have kids, small kids that really depend a lot on you. So leaning on others, and it could be for the Latina in me. I have an extended family, and those of you that are Latina, it's like a cousin, and not really cousin, but yes, cousin. So you really have to, it's that vulnerability, right? To say, I need help, and it's okay. You are enough. So,
Yes.
And to cushion, okay, go ahead.
No, that's...
And then I think watching my mentors, I have felt the same. I have this one mentor who was the first Hispanic woman to get a PhD from Yale. And I always used to call her the iron fist in a velvet glove. And then later she would share, as her career went on and I came out of undergraduate, she tried to become a president of a college and didn't get the position. And was really open with me about that as her mentor. Like, I failed, but she didn't get angry. She worked more, got up again, ended up in a better position as a president at another college, and kept going. But she shared that so openly with me, but without the anger, with some indignation towards the institution, but with drive and love. And she was still the iron fist in the velvet glove. She still had that gentle touch. That really moved me to know I was going to fail. And I did fail my first attempt at medical school, getting in. I didn't get in. But because I had learned that lesson from her, I didn't freak out. It's like, stay calm and carry on was like the lesson, but stay strong, stay gentle. Stay gentle to yourself and the people around you. And when you need the iron fist, you got it. But it doesn't have to be used every day. And that was really so important for me. And I think one of the things I try to do now as I'm starting to teach more residents and be around more clinicians that I supervise is gentle but firm, and we're all going to fail. I fail all the time. I make mistakes every day in medicine where I go back and I clean it up, and what I do is just be really honest with it. Like, hey guys, I made a mistake today. And I find that people appreciate that human aspect again way more than me being some super person. Yeah, Dr. DeJulio, she messed up. Good. I can make that mistake and then tell her about it without hiding it. That's really important to learn.
Yeah. So the only other thing I'll add is I think those are great advices by all the panelists. But if we think about our young women, the populations that we serve, in some cultures, the superwoman phenomena is more prevalent than others, like where there is just inherent expectation that you have to take care of the home, you have to take care of now women are more professionally trying to accomplish as well. So nothing has been taken off the plate. We just have added more and more to us to show ourselves that we can do it. And that's what we are trying to do every day. But I think one of the things that we can do with the patients or the young women that we come across within our populations is like working with the parents, like the mothers, showing them as the role model for their own young daughters, so that how they can take care of themselves, and that can get transmitted to the patients that we see, or the women who are growing and then can learn from their immediate senior members. So that intergenerational mentorship is so important, that we can show ourselves that we can make mistakes and still gonna be okay, and change this pattern that has come from one generation to another to another? Like, how can we get to that? How can we, the facilitators as a mental health professionals, in achieving those goals?
Great.
And I think just one more thing on the whole Superwoman schema is normalizing, and this is especially important for physicians, but for everyone, normalizing rest and the importance of rest. And that, the whole work hard, play hard, but that, again, we're not machines, and we do need downtime, and we do need lives outside of our professional identities, and that rest is an important part of being human. It's what allows us to be creative and, dream and come up with ideas to solutions to tough problems, and normalizing that and making sure that we make space for it for ourselves, role model that, and then make space for it for others, and remind our mentees of the importance of their complete well-being to break down that schema as well.
It's so interesting to think about. Early in my career, I probably did not normalize rest, and I don't have that problem anymore. I get my rest. But early on, you're juggling a whole lot of things, and it's very difficult to really normalize that concept, because you're like, I only need 4 hours. I need more than 4 hours. Okay. So, Dr. Malhi, LGBTQ plus girls and young women reported that barriers to assessing mental health care included fear of discussing their mental health concerns, not wanting to ask their parents, fear of not being taken seriously. As a psychiatrist, what can you do, and panelists can also chime in, to help overcome these issues with these young women?
So I think this is very, very, very good question, considering that when we are dealing with minoritized populations, how can we provide that trauma-informed and culturally informed care is such an important part. So one of the things that we have done within, from a organization perspective, in addition to providing more trauma-informed care, within the organizations, how can we provide that safe space for them to come in and get the help that they are looking for? Could be simple things. For example, within our electronic medical health records, we have space for they, them, he, she, he, her, he, him, she, her, so that even the staff members who are not familiar with that patient is aware of their identity. And similarly with their preferred names, preferred pronouns. So we have made that conscious effort to acknowledge their presence and respect them the way they want to be, and be able to provide the care. We also do have a gender wellness program where our therapists are particularly taking care of this vulnerable population to provide that culturally informed and trauma-informed care. So I think for me, it's important as psychiatrists as being aware of their experiences. And if you don't know, ask them. I think we can act like we may not know lived experience of every individual that comes in our clinic. So it's really important for us to be humble and express that humility that maybe I don't know. Tell me more about it so I can understand. So I think that is really important for us as a providers to show that empathy and compassion when we are taking care of this patient population.
Empathy, compassion, humility. Thank you. I know that we have a couple of questions from our virtual audience. So, Dr. Escondrias, will you read those for us? I don't think the mic is on.
Oh, there we go.
There you go.
Yes, so thank you to those on Zoom that are submitting questions. We appreciate that. Also, thank you to those on YouTube watching right now. We appreciate that too. And if you're in the audience here physically, please know you can come back here and ask your question. So first question, I would appreciate it if the speakers addressed the rise in sexual trauma and its implication on young women. How can victims be identified more effectively and referred to the appropriate healthcare practitioners?
I think that the first thing is to be screening for sexual trauma. Part of what a missed opportunity is, especially when it's not standardized. So if that is not part of what you're doing for each patient, just like I know psychiatrists will screen for suicide, sexual trauma should be part of that, must be done, especially for adolescent women when it's a vulnerable time anyway in your life. And if you are feeling isolated already, you, the psychiatrist, or you, the mental health provider, might be the only person that they're going to be able to really talk about this. So put it in your screening. And then you would be able to, if you don't know what to do with the information in terms of resource, the American Psychiatric Association has a lot of resources up on their website, and even at the district branch level. That's another resource that people don't really utilize. At the New Jersey Psychiatric Association, for instance, that's my neck of the woods, you can call the district branch and say, hey, do you have a psychiatrist that is working on mental health and specifically trauma-informed care? We would be able to help you out with that. So put it in your immediate screening that you're doing for each and every single person that comes to your office would be the first step.
I think it's hard to screen for this in some ways. I agree. Yeah. I think it's nuanced. It's nuanced as hell. Most sexual traumas now being experienced by young women are online. They're being sexually exploited, trafficked in some ways, sexual explicit pictures that are redone through AI to make them look like them, that they're not them. There's been plenty of school systems across the country who have run into these episodes of rings of people being sexually exploited using AI. It's gone to court, it's gone to criminal courts, and so it might be a very nuanced question that opens the door to somebody being able to share, such as, has anyone ever taken a picture of you that you didn't like? And that may be one of the biggest ways we can actually find out young women who are being put into these circumstances. Or have you ever taken a picture of yourself and shared it and then regretted it? That may be another kind of question. And I think you're right, we have to be more diligent about it, and maybe it's our own hesitancy, our own cultural worries about sexuality that makes us not ask the question. And so that's us thing that we have to work on, breaking down our own biases when we talk about sex with young people.
Thank you so much. A follow-up to that is how to deal with and support a child presenting with sexual abuse and exploitation. How can one shield the child from stigma attached with sexual abuse as a sexual abuse victim?
So I think,
Are we going to call him a victim, or are we going to call him a survivor? And then so the way we frame those words are really important, and words matter. And I'm going to let the child psychiatrist actually say more.
Thank you, and thank you for that. Yeah, for that.
Yes, yes.
No, I think this is really, really important, and providing that safe space, not just in the office, but outside the office as well, it's also equally important. So if you come across a child who has been sexually getting exploited or has been in the past, first important thing to ensure is the safety. Is the person in contact with the perpetrator at this time or not? And then informing the authorities where it need to be. So I think using the resources, like within our state, we have programs that particularly support children, adolescents who have gone through trauma, connecting them with the resources. That's where our community health workers come in place. As a psychiatrist or as a therapist, we may have a busy schedule, but we don't want to miss the beat on how we want to help our patients. So having these extenders that can help support the work we aim to achieve with our patients is so critical. So we have those community health workers who know the resources. We make the referrals, connect them with those resources. And then as a mandatory reporters, you have to report the authorities to ensure the safety of the adolescent or the child that we are having this situation with.
Could I add that another factor is if we utilize the police department as part of our multidisciplinary team, and we train them to how is it that they're going to be approaching? Because some of these cases, they will need to have a police officer or somebody in law enforcement to be involved. And how is it that we can train for them to not only keep the child safe, but also do it in a manner that is not re-traumatizing? I had the opportunity recently to hear what some other nations, specifically Spain and South Korea. So there was this presentation, and they were talking about this very comprehensive policy that they have enacted in both places. And it really involved that multidisciplinary team, but not in the way that we're used to. They really expanded it to the courts, to the judges, police officers, because again, their struggle is that here in the United States, we have a process and there are ways to do this, but there are some countries that don't even have that. So they have to start off with policies. So we already have the policies. Our job then will be to make sure that they can be enacted in a way that is safe and not re-traumatizing for the kids.
So to add to that, within our state, specifically the counties that our organization is situated in, our behavioral health department has collaborated with the county police. So we have a mental health professional that goes everywhere, especially for these calls, as a part of our collaboration with the county police. So that helped them to provide that more trauma-informed care as a frontline worker, and then the police officers, law enforcement comes after that. So that builds the bond. That how do you make them comfortable and not fearful of the intervention, that they can get the support.
And you know, one thing that I do that I'm just thinking about, I should expand it, but I work with the police officers where I work, and it's mostly about how to interact with crisis with people of diagnosed disorders, right? So that but now that I'm thinking about it, one thing that we could definitely do is to expand it to automatically include sexual trauma as well. So I'm going to go back and start working on that. Yeah. But to make it more robust.
Yeah.
I think it's important to give emotional validation to survivors of these events, be they oftentimes young people who are being victims of sexual abuse. They're being abused by people they know. They may be dependent on them for care, for food, economy, housing. There is so much shame and worry and anxiety in a lot of these survivors that lasts for a long time, that we have to realize they're on a healing path, that they're survivors, not victims, and we have to give them that emotional validation that what they did, raising their voice, was appropriate and good, and just on a very one-to-one level, validating the courage it takes for someone that young to say, I'm being hurt.
Thank you. And this is actually raising a lot of conversation on Zoom, so there's more follow-ups on this. In addition to the sexual aspect, how about the verbal and degrading abuse that happens to young women by a parent or guardian? What guidance would you suggest?
So what we have seen is we have to understand first, there are where it is coming from. If the parent themselves need more help in those circumstances, goal is to heal the family together, not always okay, there is abuse happening, they can be together or anything like that. So I think understanding where it is coming from, usually physical abuse is definitely not something that can put the child at risk. If it's needed, then we need utilize the whatever law authorities we need to have. But I think many times when you look at the trauma, especially the verbal abuse, it runs from generation to generation. It could be a pattern in the family that the parent may themselves been verbally abused or physically abused, and that's what they're transmitting to next generation. So having that open dialogue with the families, with the parents, that what do they think about this, what the child is reporting or adolescent is reporting, and what are their thoughts on it, and how do they envision it? Do they see it as a problematic, or this is how they feel like it's a right way to discipline. So having those conversations can be really important before we take the next step, and then addressing then if the parents need to be connected with appropriate mental health services, we have done that. We have a collaborative clinic, child and adult clinic. So we take those referrals as a priority referrals so we can help the family together, so that they don't have to have a long waiting list or things like that. So we have done extra steps to ensure that whole family is in the healing process.
And doing so is definitely can be delicate and difficult. Having those conversations with parents is an art, not a science. And encouraging them and moving them slowly towards family therapy as a great modality is important. Also, support groups and things from things like Mental Health of America, NAMI, in terms of family to family, how to have more interpersonal effectiveness during challenging times is important. But it's a hard conversation as a clinician to broach. I'm glad that our Zoom viewers are asking these questions because it's an important one, and it should be addressed head on. So I agree with Narpinder there that taking it on, having the questions, asking the tough questions, but it does require those kid gloves to ask in a way that doesn't shut the parent down, but invites them to be curious about alternative ways of communicating with the child.
It's about a gentle cultural understanding. I think you were really touching on it, and I just wanted to add a little more, like, culturally speaking, do we understand the generational trauma that the family's been through? Is that playing into the interactions between child and parents? Is this normalized in some ways because of the generations of trauma? And are they willing, and are we willing to offer other alternatives that Dr. Wills was saying, like with a gentle hand of, say, when your kid comes home late from school or late from the party, rather than a screaming fit, what would be the other options that would be culturally still, viable and would feel good for them? I think that's an important part of this because a lot of it is cultural.
I have to say it's not easy. People do fire you. At times they don't like what you're saying. But I think it's an important task that we do every day.
Yeah. And in terms of resources, there are helpline. I'm thinking of one in particular is when it's a specific support line for moms with children with disabilities. Because what ended up happening is that we knew that there was this increase of moms getting very frustrated and they didn't know where to go. So this particular helpline came about. And some of the results about studying this particular helpline is that because they had a person and it was a peer-to-peer, so it was moms with children with disabilities talking to moms with children with disabilities, and they were able to talk about that frustration because sometimes that is a cause. I'm not saying that all the time, but some of it was that frustration, feeling isolated, what do I do, overwhelmed. So that's another resource to have, and it could be tailored to different populations.
Thank you. And here we have more questions, don't you all worry. So in addition, this viewer is asking, when you think about an additional vulnerable age group, such as girls in kindergarten or primary school, what support do they have possibly at the school when it comes out to reporting any sort of physical abuse that they may be experiencing?
I think within our schools, teachers
are mandatory reporters.
Yes, teachers are school professionals are mandatory reporters. And in addition, if there are integrated mental health professionals in the school, which many schools do have at this point, they can be a good resource to understand the situation. And if that needs to be reported, that certainly would be the next step. But also ensuring the services, the resources that the family need to address this, whatever is happening in the family dynamics is also critically important.
That's why that school-based programs are, to me, they're so critical. And it's not only the teachers, the nursing staff that's in the school, they can be trained and be comfortable with picking up the red flags, and that includes all types of abuse.
Can you speak a little bit about the school-based programs in certain areas? Because I'm thinking school-based programs cost money. So that means some kids may have the opportunity to have these school-based programs, and those who may need it most may not have these resources. And just from your experience.
Well, I can tell you my experience is that the school-based programs are state funded, and that's a big issue because unfortunately those are the type of programs that get cut from budgets because it's not an immediate gain. So I think that, again, it's that advocacy. So what can we do? Continue to advocate, and I do this at the local level, and I really encourage people to do it at the local level because the majority of these programs are really state funded. And when you look at it,
I think we also need to allow bachelor's trained persons to be liaisons in schools. I know in Denver we have mostly master's trained in our schools, but there's a limited amount of LCSWs, LPCs, and so what we've done is partnered with bachelor's trained persons who are bachelors in psychology or early childhood career, who are maybe on the path to becoming a teacher, where they can be in more remote places, have the number of our community LCSW, LPCs, and our psychiatrists to at least spread them out farther in the rural areas. And I'm specifically talking like eastern plains of Colorado and southern Colorado, very rural. It's hard for people to want to live there because it's very rural. And so if we can get more people that have at least a bachelor's training, they can take the wheel on issues that arise in schools and get to the next step. And that is still state funded in Colorado, but that's one of the things we've done.
See, and this is why telepsychiatry becomes so critical. And we need to really move from having it it has to be permanent. We know from the pandemic that having, especially for rural communities, having that telepsychiatric, even a hybrid model, really increased the access. I'm not from a rural state, and in New Jersey, I personally witnessed people having such a low no-show rate. So we actually were looking at some of the statistics for the clinic, and the no-show rate, once we instituted the telepsychiatry, went really, really down, and it was fast. So and I started asking some of the patients, and they're like, well, now I can take my lunch break and connect with you guys, which we don't think about it, but it is so critical. Sometimes you only have literally half an hour, right? And at least if I can be at my car, have lunch, and then still ask you about what should I do right now, that would be the way to go. So telepsychiatry really should be permanent, even if it's in a hybrid environment.
And one of the questions I wanted to make sure I asked the panelists, because it was part of a goal of having the whole thing, is about referral pathways and connecting these young women to mental health services. So we've been talking a lot about school-based programs. We talked about sort of if people come to their community entities like religious and churches and synagogues, et cetera, or they may go to their primary care doc, whether it's their pediatrician or internal medicine. How do you strengthen this referral pathway to get them where they need to be in terms of getting their mental health services?
I think networking is very important. We need to build that relationship with all these organizations, like either primary care or the faith organization. We need to be part of them so they know how to reach out to us. I think that was when we first established our clinic, I can tell you real-time example that for 3 months or 4 months, we had a child psychiatrist, but we were not getting any patients. The thing was that, my organization was okay. Organization was saying that, okay, we're building, that's fine, we have time to, but nobody knew that we existed. So unless you don't get the word out and make relationships, no, they are not going to know what is the next step. So we are the pioneers there. Like as a mental health professional, either psychiatrist or therapist, I think it's really important to know from which communities your patients are coming. So we get to know them and make that connection, and so that they feel comfortable that these are the people we want them to go, and this is where you're going to get the care. I don't know if you have any other.
Well,
Yeah.
I think everybody knows that I'm very pro collaborative care model at this point. And that's part of it. It's integrating that you will have, especially for one-stop shopping, if you may. The primary care psychiatrist has already engaged that particular patient, and having that care manager working with the psychiatric consultant within the collaborative, again, it's a workforce multiplier, and it's in a place where the patients already feel comfortable because they are dealing with whatever chronic medical illness they have. So that extension of also treating your mental health, it's a win-win situation.
I think Gen Z and Gen A, the generation younger than Gen Z, are often really good consumers. Maybe they consume too much. I wouldn't say that, but TikTok, Insta, WhatsApp, LinkedIn for our professionals, for the colleagues who want to network with. But oftentimes, I'm finding great engagement on our TikTok, and Duke University is doing a huge group of their child psychiatrists talking about AI, TikTok videos to help engage people in mental health, to get the referral network tighter, because people will self-refer, especially Gen Z and Gen A. They are looking for mental health to consume, and so bring it to them where they're already at. The boat is sailed. TikTok's there if we like it or not, but go to where youth are, and then that reference network becomes that web becomes so much tighter, because you can tag all sorts of other things in your community on a TikTok or on an Insta post, and bring just short messages of positive affirmations and a place where they can go quickly. And then for colleagues, networking with colleagues is more complex.
So I think one example could be like if we are seeing a kid having that one small conversation with the teacher, and that teacher can become a source for many other kids that are going to come across them to be able to. So having them the awareness that we exist and we are here to help, I think that's the way to make it strengthened.
And Dr. Wills, what about the APA as a membership organization? Is there anything that you would envision that we as an organization could do to facilitate sort of this referral?
Yeah, it's a great question. I think at the national level, we work very hard to build those relationships with the other APA, the American Psychological Association, the American Counseling Association, the National Association for Social Work, NASW. It's important that nationally we build these sort of, if you will, meta cross-functional teams so that we can all learn how to work together and support one another in community models of care. Because we know, first of all, even if there were enough psychiatrists, we can't do it alone. We need other disciplines and other practitioners to use their skills to continue to galvanize and strengthen young women and their families in the communities in which they live. So I do think that there is a role that organizations like the American Psychiatric Association can play in forging those connections and ties interdisciplinarily.
Yeah. I know that we're coming down to time, but I see a question from the audience.
Thank you so much for the insightful expertise and for serving as your panelists. I always love attending these events, and of course I have a policy question for all of you. So if the reconciliation bill is passed, obviously it was passed in the Senate and now going into the House again, which will mean that there's going to be $1 trillion cut into Medicaid. And we know that communities, underserved communities, communities of color, are primarily dependent on Medicaid. So what advocacy is important. So thank you so much for stating that. But what can we do beyond advocacy to prepare for potential ramifications of the impact that this will lead to a decrease in people becoming uninsured over the next 10 years? Also understanding that the bill will also lead to $375 billion in provider or reimbursement for providers. So that also impacts your workforce. So any tips that you could provide, or insights or hopes, or what can we do as a collective effort to really help, probably set for this Medicaid reckoning that is upon us?
Also, if you can identify yourself, your name and your association.
Yes, sorry. Omar Escontrillas, and I'm with the National Health Council. We're a patient-centered advocacy organization here in DC.
Thank you.
Thank you for the question. I think I want to start off by saying that, yes, it was very disappointing to hear the fact that it did pass today and it's now going to go back. So my personal view on this is that it was definitely a very difficult news, because I know that a lot of my patients depend on Medicaid. So one of the things that I have done is actually reach out to my legislators. We did send, as a leadership group, we did send an action alert to our members and have encouraged every single psychiatrist that is a member of the American Psychiatric Association, and those that are not members of the American Psychiatric Association, to contact their legislators. There still is time. So you were talking about hope. So there is still time. We now know that the information did come out about what it really will entail, not only for the budget deficit, but how is it that we are going to have 11 million of lives that are not going to be covered, when we already know by data that people that are not insured will have, and again, it's the data out there, that they tend to have worse medical outcomes. And that also applies to medical psychiatric conditions. So the hope is that we will continue to advocate. And I really encourage every single one here, and those of you that are listening, please contact your legislators. If there ever was a time, this is a time for you to put your advocacy hat on and do that.
And there is a midterm,
Yes.
that's coming. And I think that it's very important to protect Medicaid, Medicare, Social Security, our youth. OBGYN care is huge on my list of things that I worry about. In rural Colorado, people are driving 3 or 4 hours already. But when this happens, if it does happen, people will not have basic OBGYN care, much less mental health. They will be driving 3 to 5 hours to the closest hospital. That's a huge risk, considering we're talking about women today, and women of color already have higher rates of maternal death. That will only go higher as we see this, if we don't kind of raise the red flags about children and women's health. Our organization in Colorado has started to collaborate with other community mental health institutions and consolidate in so much as, pack in what we have as assets together to start working together more, and not deforming the organizations, but a tighter collaboration, sharing of funds, sharing of buildings, because as we come into these cuts, Colorado itself is not in the worst shape, but we lose all the half of our federal funding. So that's where we started, and we know we have about a year before these actual cuts come into place, 2027. Again, there's a midterm, there's time to prepare, advocate, and prepare. I think that's what our organization has done, and I think is wise to start thinking about doing if you're in that community space.
Connecting with the regional organization, that's something we can do. Mm-hmm. I would say that it is scary. It's something that we all have to be very vigilant. We all have to do our due diligence. Each person's contribution will matter.
Yeah.
So what we can do within our scope does matter. So sometimes I know people feel that, oh, one vote, what is going to do? Like, okay, even if I do that, what's the difference? Oh, I'm too busy, maybe others are voting. I think those type of thoughts I have heard from other people. It doesn't take too long. It's just, I would say, less than a minute or maybe minute, 10 second max to sign those advocacy alerts and do it.
Yeah.
Thank you. You have another question from the audience?
Yes, thank you for all of what you are presenting here. My question is centered around the intersection between the criminal justice system and what you do as professionals. And I bring that concern to the table because about a month ago, I got a call from a young lady in New Jersey who was just at her wit's end. And she said on her birthday, she would just take her life. And so I called, the 988, that new emergency number, couldn't get any help. And so they said, well, just call the police station. I was frightened to death to do that because of what has happened in the past when we call the law enforcement in and they're not trained to handle these situations. It always winds up being something on the other side that we don't like. So I'm concerned about how we can, as advocates and you all as professionals, can bridge that gap or bring that intersection between the criminal justice system and the training that they need to recognize when a person is having a crisis so that it doesn't wind up being a death sentence.
Also, can you identify yourself?
Oh, I'm Linda Wharton-Boyd. I'm with the DC Health Benefit Exchange Authority and also chair the B.B. Moore Campbell National Minority Mental Health Awareness Task Force.
Thank you.
Thank you for your question. Being that the person is in New Jersey, the one thing I can tell you is that we do have the crisis team that will go with the police officers. So there is that model that actually came from the West and that we have incorporated. So that definitely mitigates some of the concerns. I participate with the training of police officers. And one of the things that I do during the training is explain what happens when somebody has an acute psychiatric episode, specifically if it's either a manic episode or a psychotic episode. How is it that they can pick up immediately when they go into the home in terms of what is happening? And the fact that now they're coming in with a clinician that is part of that crisis team center, and then we'll bring the patient to the emergency room so that we can then have the psychiatric team evaluate. That really helps out. But the issue is that not all states have that particular program. So how is it that we can, as psychiatrists, and again, it's how is it that we're going to educate the legislators, and why is it important to have this type of program? And I can tell you that the whole, it's not only psychiatric or the medical professionals. The fact that it is in New Jersey really had to do with multidisciplinary team people going to the legislators. So it took clinicians, nursing staff, medical staff members to be able to let people know why the program that was coming from the West, why is it that it was important to have as a safety measure.
Yes, and I just think we need to develop a national model for what to do, because this is happening all around the country, and parents are afraid to call to get help because they feel their children will not, will be murdered or shot by the police officer, or because they don't understand it. So I bring that up because I really think that one of the priorities we should consider is how do we address the intersection between this field of study and the criminal justice system.
It often comes down to a lawsuit in the state of Colorado. A young man 3 years ago was in Jefferson County. He drove his mom's car into the snow, got stranded, and was killed by the police because he was in a psychotic episode. That county, Jefferson County, now stepped up to the plate, but it took a life. It took a death of a young man, a man of color, to change that county to want to get trained. So it's county by county, sheriff office by sheriff office that we've had to go through in Colorado and say, let's do it. Most counties have done it now. Most counties have had mandatory training. They have a 988 crisis mobile team, but it took it took litigation and a death of a really innocent young man in a mental health crisis to get it to happen, and it shouldn't have to. And so that is a huge project coming in the next, in the coming years, I think, to get every county to be trained.
Thank you, everyone. I think this has been a very fruitful and educational discussion. Let's please give our esteemed panelists a round of applause. And thank you to those who joined us virtually. And before we officially end the program, I would like to thank each and every panelist on behalf of the American Psychiatric Association, the More Equity and Mental Health Initiative, with our greatest appreciation. And we'll start with our APA President, Dr. Miskimen Rivera.
Thank you. Thank you. Appreciate it.
It's a real thing.
Thank you. This is an honor. Thank you.
Thank you. Thank you so much for coming.
Thanks for coming.
And of course, we cannot forget my boss, the CEO and Medical Director, Dr. Marquita Wills. Thank you so much, Marquita.
Thank you.
I know her schedule is very busy.
So happy to be here. It's such a privilege.
Thank you.
Thank you, Regina. Great job.
Dr. Narpinder Malhi. Thank you so much, Narpinder. Thank you. Here you go.
I'm so honored, and thank you for having me.
And Dr. Adriana Minigotes de Julio. Thank you so much.
Hey, that's thank you in Navajo. Thank you so much for everybody.
Thank you. And thank you, everyone, for joining us. I hope you have a wonderful afternoon.